Okay, today we're going to talk about stroke and TBI. This is kind of a representation of what a stroke is. This is not a very good representation. It's a good picture, it's a good background, but not a good explanatory picture. Okay, so what is a stroke? Well, in the most simple terms, it's a lack of blood flow to the brain. That's essentially what it is. One entire lobe or just a small part of the brain is lacking blood flow, and that poses some problems. We'll talk about those in a second, but it's essentially a lack of blood flow to the brain. There's two types of stroke. The first is ischemic, the second is hemorrhagic. Hemorrhagic, from the word hemorrhage, that should kind of clue you in on what's going on there. But let's talk about ischemic first. So ischemic is a blockage, a clot of some sort, a clot or some other kind of blockage, like cholesterol or something like that, moves through the vein, and then what happens is it sticks in a part where it gets maybe a little bit more narrow, and the blood flow can't get beyond that blockage. So in the brain, because a stroke is a lack of blood flow to the brain, so if this happens in the brain, this is going to impede blood flow from getting to some structure in the brain. A hemorrhagic stroke, on the other hand, is, like I said, a hemorrhage. So that's when the blood vessel opens and blood starts spilling and pooling into the actual cranial cavity, and it'll push against the surface of the brain and cause more problems just from pushing on it. I'll show you some pictures of that in a second. But first, when we think about stroke and these kinds of problems, an ischemic stroke, a hemorrhagic stroke, I think sometimes the mechanism isn't 100% clear because, or at least it wasn't to me when I was in graduate school, because I think, why does a stroke only happen in the brain? It's a problem with blood vessels, but why does it only happen in the brain? It doesn't. It's just called different things. It happens everywhere in the body, or it can happen everywhere in the body, but it's called different things. A stroke is in the brain. DVT, which is deep vein thrombosis, that's like an ischemic stroke in the legs. That's what that is. So it can happen in the legs as DVT, or it can happen as a varicose vein. Varicose veins are on the surface. If they start bleeding, they can get nicked, and then they can bleed, and they can bleed quite a bit, or they can just kind of start bleeding on their own from some small amount of trauma. That's like a hemorrhagic stroke, but that's happening in the legs. It's not, the varicose vein bleed isn't as problematic. Sometimes you can bleed so much that you need to get medical attention, but sometimes it'll just go away on its own, and it's not nearly as life-threatening as a hemorrhagic stroke. A DVT can cause problems because that can impede blood flow to other important parts in your body. It's a deep vein. If it's not a deep vein, because there are types of thrombosis that aren't deep vein, they're more like surface veins, and those are not a problem. In fact, my mom had one of those shallow vein thrombosis things, and she was worried. She went to the ER, and she's like, I think I've got a clot in my leg. And they're like, you do, but it's not. They did the ultrasound, and they're like, it's not the deep vein. It's one of these just surface veins. It brings blood to the surface of your leg. There's a lot of other veins that are serving the same area. So it's fine. It's totally fine. It'll go away on its own. And it has, mostly. So it just kind of dissolves on its own. They monitor you in case it moves. But that's essentially the same mechanism as an ischemic stroke. It just happens in a different place. Or the varicose vein bleed is like a hemorrhagic stroke. It just happens in a different place. It can happen in the lungs too. So you can have something called a pulmonary embolism. Well, that's a blockage in the lungs, which I'm showing you down here, bottom right about here. This is like a blood clot in this vein right here. And essentially what that does is it doesn't allow blood to be oxygenated in that part of the lungs because there's an embolism. A pulmonary hemorrhage can happen too, and that's when blood starts coming out of the vein in the lungs. That also doesn't allow blood to be oxygenated in that part of the lungs, and it can start filling the lungs up with blood. So these pulmonary embolisms and pulmonary hemorrhages, those are really serious ER type things, as is a stroke. Deep vein thrombosis is serious, but shallow vein isn't. And also varicose vein bleeds are usually not serious. But so the point here is, if you're confused about why a stroke only happens in the brain, it doesn't. It's just called something when it happens somewhere else. A stroke only comes from the stroke region of France, like Champagne. So it's just called something when it happens in the brain, but it can happen all over the body because blood vessels are everywhere. It just has a different name in different places. Okay, so now that we know this, let's talk about the risk factors of stroke. A few risk factors: high blood pressure, high cholesterol. If you're a smoker, that's a risk factor. If you are obese, that's a risk factor. Diabetes is a risk factor, type 1 and type 2. And trans-ischemic attacks are also risk factors. So I think most of these are pretty self-explanatory. If you or somebody in your family, or once you start practicing, if you have a patient that has any of these risk factors, high blood pressure, there's medication for. High cholesterol, there's medication for. Also, you could just eat Cheerios or oatmeal. Here's the thing: I put so much butter in my oatmeal that I think it just cancels itself out. It's like the oatmeal's really good for getting rid of cholesterol, but then I put butter in it, and it's like a totally cholesterol neutral thing going through, because it's like takes some away but puts a whole bunch more in. It's probably worse for me than it is better. I don't know, but it tastes great. Anyway, smoker, try to convince him to quit. There's so many horrible things that come with smoking. I mean, like stroke, yeah. Cancer, yes. Emphysema, absolutely. Just, there's nothing good that comes from it. Obesity, this is like towards, overweight doesn't have as much of a risk for stroke, but once you get into the upper realms, into the obese range, it does. It's a lot harder. It's a lot harder to encourage somebody to lose weight than it is to get them to quit smoking. So if they have these other ones, focus on those other ones first, because there's a lot of these are a lot easier to fix. Diabetes, medication. Trans-ischemic attacks. What the heck are those? Well, those are sometimes called mini strokes. And essentially what's going on, you can kind of get the idea here, like it kind of sounds like an ischemic stroke. Essentially what's going on is it's a very temporary blockage of blood. So you have some strange sensations that kind of feel like a stroke. So maybe like a little bit of temporary dizziness with a little bit of facial drooping. And if that persists, it's a stroke. But if it doesn't, that's considered a trans-ischemic attack. Usually trans-ischemic attacks are so quick that people don't have long-term damage from the trans-ischemic attacks, because it's really the lack of blood to the parts of the brain that cause the problems. So the trans-ischemic attack is just a really temporary lack of blood. No brain tissue has died. It's still okay, but those people who have a trans-ischemic attack are much more likely to go on to have a stroke after they've had a trans-ischemic attack. Something's getting caught somewhere, and it's very likely that they'll have a more complete ischemic stroke after having trans-ischemic attacks. So a lot of these risk factors, you can try to mitigate them, but trans-ischemic attacks, it's time to talk to a doctor for sure. And then get some ultrasound to see what's going on within the veins. Okay, what are the symptoms of a stroke? Well, one way that you can remember this is the acronym FAST. I was going to say it stands for FAST. Not true. It stands for facial weakness, arm weakness, speech slurring, and then time to call 911. If you have all three of those, time to call 911. It's over here on the left. It's over here on the right. So you got a double time on your screen. Face, arm, speech, time to call 911. So what's going on here is facial weakness. If there's like the person can't make facial expressions, they can't smile, or the mouth is drooping, the eyelid is drooping, especially just on one side. That says dropping. It should say drooping. I spelled it the wrong way over on my side. Arm weakness, like you can't reach for something, you pick something up and then just drop it. Clumsiness with walking, so there's some balance issues there as well. That would go under the arm. And then speech slurring, this kind of goes with facial weakness. If you have facial weakness or facial drooping, then of course you're going to be slurring your words, difficulty producing the words, but also difficulty understanding words. So if it seems like someone is confused and maybe they've got some facial drooping going on, that's also indicative of a stroke. And so if those are happening, it's time to call 911. There's a sub-term here, which is be fast. And that is for balance and vision issues. The B is for balance and the E is for eyes. Sometimes people will just not be able to make sense of what they're seeing. They won't be able to see where their phone is, even if they're looking right at it. And balance, we kind of talked about that. Balance kind of goes along with the arm weakness, but this would be with the legs, not able to stay up or feeling dizzy. So fast or be fast, either way, the last one is call 911. With a stroke, either kind of stroke, ischemic or hemorrhagic, the most important thing is you have to get medical attention as fast as possible. So look for these warning signs, and if you see them, you gotta get an ambulance to you as soon as possible. Or if you are close to an ER and you can get there, get someone to an ER. Gotta have medical attention as fast as possible. There's drugs, clot-busting drugs that can take care of an ischemic stroke, and there are surgical options for a hemorrhagic stroke. One is worse than the other. We're going to talk about that in a second, but either way, you have to get there quickly. Okay, let's talk about the hemorrhagic stroke. This is a graphic picture of a hemorrhagic stroke. Probably should have warned you about that before it came on. So what happens with the hemorrhagic stroke is the blood vessel begins to bleed. So beyond where the bleed is, now those veins aren't getting blood flow. So it's kind of like you have the effects of an ischemic stroke from beyond the bleed, right? Like distal from the bleed, those areas aren't getting blood. But you also have, coupled with that, the fact that blood is coming out of the vessel and now it begins to pool in the brain. You would call this an intracerebral bleed. You've got a bleed in the MCA, which is the middle cerebral artery. Sometimes you could have these in subarachnoid areas, which is in the meninges, in the area around the brain. But because of the pooling, take a look at this picture right here. If I trace out the brain, you can see brain tissue here, and everything that I like within the area that I just drew, that's not brain tissue anymore. That's just blood. That's congealed blood. So this whole area right here, that should be brain tissue, but it's not. The skull doesn't expand. So when you have a bleed like this and the blood starts taking up space, all that mass has to go somewhere. And where it goes is it just gets smushed around. So you can see that this hole right here, this is the ventricle. This is where cerebrospinal fluid should flow. On this side, it's much smaller than it is on the left. And that's because the brain had to get smushed into that area. Over here, you see this whole region of the brain has been smushed down, like take a piece of cauliflower and compress it like that, because the blood had to go somewhere and the brain tissue had to go somewhere. The problem, there's lots of problems with this, but the main problem here is that as the brain has to be pushed and contorted in ways to make room for the blood, it shears apart the neuronal connections. And when those neuronal connections are sheared apart, that's when areas of the brain get damaged. Too much damage, like this one here, and it's a fatal injury. This is the same kind of thing on a CT scan right here. You can see this white part right here. That's where a bleed was. And so the brain is all this gray part around it. And you can tell again right here, this is a ventricle where the cerebrospinal fluid should be. And on this side, it doesn't exist because the brain has been pushed into that region. So these aren't good. Hemorrhagic strokes have the worst prognosis because there's a lack of blood flow from everywhere from the bleed on out into the brain. And then there's also just this pooling, this pressure, always increasing pressure from the blood that's pooling into the cranial space. Vomiting and headaches are also common with this type of stroke. So all the things that we talked about before, be fast, and then also vomiting and headaches. Vomiting because it starts pushing on regions of the brain that control vomiting, essentially, and then headaches because of these shearing forces within the brain. Usually what's going to happen here is a surgical repair. Have to get into the brain and then cauterize where the bleed is actually happening. It has to be cauterized, surgically cauterized. So they'll put suction in to remove the blood. They will cauterize the parts of the vein that are bleeding, and hopefully the person makes a recovery. But like I said, hemorrhagic strokes have the worst prognosis because you have two things together, lack of blood flow and the pooling blood, the pressure from all that pooling blood. This is another picture that just shows hemorrhagic stroke. Okay, ischemic stroke. Here is, boop, there's a little clot right there that you can follow. And what happens is it moves up and then it gets stuck right there. And beyond there, where the brain turns gray after that, that's parts of the brain that aren't being served with blood flow. So a clot forms, it moves through the veins, through the blood vessels, it gets stuck in an area, and then blood can't make it to the rest of the brain. If this is caught in time, like I said, there are clot-busting medications that can be injected into the veins, and they will just dissolve the clot. That's the best. Well, I think it's the fastest. It's probably the current most accepted way. If you had an ischemic stroke, that's what would happen if you went to the ER. Sometimes surgery would have to be an option, but usually the clot busting drugs are the safest and quickest way to go. And that'll just dissolve that clot and blood flow can resume. Okay, so that's hemorrhagic and ischemic strokes. Let's talk a little bit about prevalence. So 7 million adults per year in the U.S. are going to have some type of stroke. That's quite a few. And that's just in the U.S. 87, this is the good news. 87% of those are ischemic, because remember, ischemic has the best prognosis. 13% of those are hemorrhagic. So hemorrhagic has the worst prognosis, but it is the least common of the two, and by a significant margin. So no stroke is good, but an ischemic stroke is better. There also seems to be some differences here. Genetic makeup does push that around a little bit for some reason. So East Asians have the most disproportionate percentages with 75% ischemic and 25% hemorrhagic. It's still close. It's still way more ischemic than hemorrhagic, but it changes a little bit. We're not entirely sure what causes that. It could be some genetic marker that's correlated with just East Asian descent. Typical lifestyle choices. It's kind of up in the air. It's not something that is 100%. We don't know the mechanism that causes this. We just know that it's a little bit different due to based on your genes. I'm not saying it's caused by the genes. I'm saying based on your ethnic group, it can be a little bit different. But again, the mechanism is not entirely clear. Age is the primary risk factor, though. So if you are between the ages of 65 and 74, 970 out of 1,000, 970 cases of stroke out of 100,000 people. So that's quite a few. And then when you compare that to children, it's only 2.5 cases of stroke out of 100,000. So age is really the biggest risk factor. Now, the bummer about kids is that in strokes from children that have strokes, more of those are hemorrhagic. So 50 to 75% of those are hemorrhagic. So that is not as good. Another thing that's not as good, if you... Whoops, I moved the wrong thing. I wanted to move my head. There we go. Okay, sorry about that. Another thing that's not so great is that there are a lot of racial disparities in stroke care. So we know that there's a little bit of racial disparities in terms of how you have a stroke, but these are not that. This is just like when someone comes into the ER, not everybody is treated the same in the ER. Of course, there's genetic related differences. We talked about those. There's a lack of care seeking among groups. So this is definitely something, if you come from a group that typically has low levels of going to the doctor, of seeking care, be extra vigilant for signs of stroke, and then underscore how important it is to go to the ER. There's also bias among care providers. Okay, so if you're wondering, lack of care seeking, this, broadly speaking, it just happens to be African American and Hispanic are less likely to seek care. That doesn't mean everybody, and there can certainly be white, South Asian, East Asian, Middle Eastern people who don't seek care, but that is a difference among those groups. So if you are serving that population, or if you are in that population, just encourage the people around you to go to the ER when they need to. Anecdotally, my dad is Hispanic and my mom is not, and he does not like to go to the doctor. So he's definitely falling into his stereotype. There's also bias among care providers. So there's a lack of care seeking within the population, but that doesn't account for all the differences. There's also bias once you get to the ER. Black patients are less likely to be seen by neurologists in hospitals. When you go into a hospital, you tell them when you go to the ER, you explain what your symptoms are. And if your symptoms sound like they could be a stroke, you're supposed to be seen by a neurologist or get a stroke consult pretty much immediately. As soon as that person has time, and they'll page them quickly to come do an assessment, they should. But that doesn't happen as often for black patients. That's something that has to change among care providers. I know you guys are going to be SLPs and audiologists, but if you work in hospitals, this is definitely something. It's not the only place you're going to see racial bias within the healthcare system, so this is just something to try to change if that's where you end up working. There's also barriers to care that affect people differently based on where they are. So doctor's hours don't always work for people. If you have a job like mine, doctor's hours don't really make a difference, right? Because usually I work Monday, Wednesday, Friday, and then I do a bunch of work at time that I schedule on Tuesday and Thursday, and also the weekend. But it's my time to schedule. And even those days that I teach Monday, Wednesday, Friday, if I'm not teaching a class or going to see a talk or a colloquium or something, I can go and not be grading at that time and go to the doctor. But people who have jobs like working in an Amazon facility or construction work or something like that, it's hard to go to the doctor. My dad is a weird case because he was studying to be, he went through a bunch of medical classes, and we talk about, this is 205, but when you're in 310, there's things that all teach you about the cranial nerves that are things that my dad learned when he was in school for that kind of thing. Then he quit and he went to go work construction. And this was always a problem for him, is the doctor's hours thing. He was working while the doctors were working, and it was difficult to get away. There's also problems with doctor locations. They tend to be in nicer areas. So it's harder to get to those nicer areas when you don't have a reliable source of transportation. And then also, there's a lot of socioeconomic status and cultural norms that correlate with diet. And then remember, cholesterol, high blood pressure, and obesity are also risk factors for stroke. So you've got these social determinants of health that are going to impact stroke as well. It's a complex thing. I don't know. I should have came up with a better word there. It's a complex thing. Okay, speech and stroke. 60% of people who survive their stroke have some sort of speech-related deficit. So over half, right? And we just said there's 7 million adults per year who have a stroke. Let's assume a low amount of survivability at 50%. It's higher than that. I just don't want to overquote the stats. So let's say that 50% of people that have a stroke survive. So that's 3.5 million. And 60% of them have some sort of speech-related deficit. Half of 3.5 is 1.75. So about 2 at 60%. It's roughly 2 million. So 2 million people per year are going to be new clients for you because they have some sort of speech-related deficit. In addition to the kids that have issues and older people that have other issues from other health problems, just from stroke alone, 2 million people per year. It's a lot. One really common immediate symptom of a stroke or any type of traumatic brain injury, which stroke is just one type of traumatic brain injury, but a common immediate symptom of TBI, which is traumatic brain injury, is some sort of aphasia. That doesn't mean that they have aphasia. That just means that it is a really common symptom. It can spontaneously resolve on its own in a few days. So you get somebody who has a stroke, you get somebody who has a penetrating head wound or something like that. They may look like they have aphasia. Do they go on to develop like Broca's aphasia, Wernicke's aphasia, transcortical motor aphasia? They might, but you can't tell. They might just spontaneously recover because that's a common immediate symptom. So for that reason, SLPs are often not called for until a couple days have gone by and there's been a chance for that spontaneous recovery to occur. So why does that happen? It probably happens because of swelling in the brain. So a stroke or some sort of damage is going to cause some swelling in different areas. It doesn't necessarily mean that any of the neuronal connections have been damaged. It just means that they're swelling and things are maybe being occluded. You've got trauma to the brain. So this is just an interesting side effect that happens. Anyway, point of that is not everybody that looks like they have aphasia right off the bat actually does have aphasia. A lot of that will spontaneously recover, but of course 60% of them don't, and that's where the SLPs come in. This is going to be the end of this first video. We're going to go into talking about TBI in the next one, but what I want to leave you with is this picture right here. This is a visual representation of what it's like to have a stroke, basically. When you have a stroke, you see things that almost make sense, and then they don't. Remember, we were talking about vision issues. You can be looking for your phone and not see it. You can hear things, and it doesn't make sense. Somebody could be talking to you, and you kind of almost understand what the words are that they're saying, and then you don't. And this is kind of what's going on there. So this almost looks like a jacket, and then you get up here and it's not, there's not some sleeves, the sleeves are gone or something, and then it turns into like a hat that is simultaneously like one of those balaclavas and a beanie or something, but it's really difficult to figure out what it is. Here, this looks like maybe this is a person, and there's hair coming up, and then it kind of turns into an animal or maybe an eyeball or something here. This, is it writing? Not really. So everything almost makes sense, but not quite. And this is why it's very confusing in those first few minutes of having a stroke. And the confusion can, lead people to not think clearly because they're really confused and think that they need to call 911. So if you notice this happening to you, call 911. If you're around someone and you notice all those symptoms, fast or be fast, then if they're confused and can't really understand you, you got to help them get to the ER or call 911 for them. Okay, like I said, that's the end of this first portion on stroke and TBI. The next one, we're going to talk about TBI. That should come up like about right now. There should be a link somewhere over here or over here, something like that, that'll take you to the next one. Or if you want to take a break, just find the link in Canvas.